ম্যাম আসসালামু আলাইকুম ম্যাম, আমরা এখন শুরু করতে পারবো?
Assalamu alaikum and welcome for the PHA OBGYN group. Today we have a webinar of the OBGYN of PHA, the Planetary Health Academy. All of you know. We know at the end of the year, actually everyone is busy. We are sharing today's Zoom in selective to our 50 participants. So already 23 is joined with us. And with the social media, many of the participants will join. We are hoping so. So today we will discuss on modern approaches to diabetes in pregnancy management and update. I'm Dr. Sharmin Abbasi, Associate Faculty Lead of OBGYN of Planetary Health Academia. And with us as a chairperson, we have Professor Raushunara Begum. Professor Raushunara Begum is a past president of OGSP and the chairperson of the PHA OBGYN Bangladesh chapter. And as a chairperson, Professor Saiba Akhtar will join. She is now traveling. She will join later with us. She is the past president of OGSB. With us, we have Dr. Tasbirul Islam, the founding chairman of Planetary Health Academia. And as an expert discussant, we have Professor Maliha Rashid, the former head of the Department of OBGYN, Dhaka Medical College Hospital. We have Professor Rubina Sohel, the past president of Suffolk. Professor Shamsad Jahan Sheli, head of the Department of OBGYN of United Medical College Hospital, and Dr. Soyed Rabha Bitat, the faculty lead of endocrine of Planetary Health Academia. As a keynote speaker, we have Professor Dr. Tanzina Hossain. She is a very well-known face to us and very close to us. She is now working as a head of the Department of the Endocrinology in the Green Life Medical College, Media and Press Secretary, Bangladesh Endocrine Society, and very importantly, she is now working as a convener of Women's Health Task Force in Bangladesh Endocrine Society. So I'm welcoming all to enjoy our session. It's a 1 hour session. Within concrete 1 hour, we'll finish our session today. So for the opening remark, I'm requesting Dr. Tasbirul Islam, sir. Over to you, sir.
Thank you, Sharmin, for your kind introduction. And Assalamu alaikum. Good evening to everyone joining this important webinar on modern approaches to diabetes in pregnancy. Gestational diabetes is a major and time-demanding public health concerns in Bangladesh. When Sharmin invited me 2 days ago to give the opening remarks, I sought out the data relevant to Bangladesh. Unfortunately, there are not many published studies available. I was not only surprised, but also become deeply concerned by the findings I uncovered. Recent data showed actually 25 to 30% of the Bangladeshi population are either diabetic or pre-diabetic. We are talking about one-fourth or one-third of the population, huge. Bangladesh ranked eighth highest country globally in the world in the number of adults living with diabetes. More than 60% of the individual are unaware of their diagnosis. Only 30% have a good diabetic control. When I researched further and looking at the data online and I actually learned more, actually, I found out that almost over 55% of the pregnant women do not have any proper antenatal care in Bangladesh. But perhaps the most alarming insight is that majority of the physicians who actually participated in the study do not follow recommended guideline. Majority. That is alarming. And that actually paper published in Journal of Diabetology in 2021. We all know that for the goals for fasting blood sugar and post meal blood sugar for diabetic women or pregnant population is much stricter than the non-pregnant women. I'm pretty sure Tanzina Hussain will address these critical points in her presentation. While we recognize the limitation and challenges we face, actually, we need to fix. Many actually cannot be fixed overnight. That I know, but at least we need to start, and we need to start now. At least we can work towards increasing awareness among the general population, closing the knowledge gap between urban and rural physicians, training non-physician healthcare workers like paramedics, and train the patient how to use the smartphone and the app. So thank you all once again for devoting your valuable time. Together we can make meaningful difference. Now I'm pleased to hand over to Sharmin Abbasi and look forward for insightful presentation for Tanzina Hussain. Thank you.
Thank you very much, Pratas sir. Your talk is always inspiring for us, and we are very much waiting to make a session when we're back to Bangladesh in next month, inshallah, sir. Please give us
Inshallah.
your valuable time. Yes. Without any delay, I am now over to Dr. Tanzina Hussain. We are waiting to get your information, your cardinal information, and what's actually Bangladesh practicing. Over to you, madam.
Thank you very much, Dr. Sharmin Abbasi, and thank you especially for inviting me in front of such a learned audience. And I can see my very favorite and very respectful madams here, Roshnara madam, Maliha madam, Saiba madam, and all others. I feel very privileged talking in front of them. I think you can see the slides, okay?
Yeah, full share ta jodi diten.
It's okay? Yeah.
Yes. Thank you.
Okay, today we are going to talk about the modern approaches of diabetes in pregnancy guidelines and update. You know that pregnancy diabetes guidelines are very difficult to produce because there are some ethical issues to do studies and researches during pregnancy. And so in normal diabetic population, new drugs are coming, new insulins are trying, new treatment approaches are coming, but in pregnancy diabetes, we are still, I think, are stuck in some situations. We cannot progress in more modern treatments. But nowadays, some guidelines are there which are guiding us to treat how to treat diabetes in pregnancy. And today I'm going to mostly speak about gestational diabetes mellitus, but we know that hyperglycemia in pregnancy can be of two types. One is gestational diabetes mellitus, and another is pre-existing diabetic women who become pregnant later. Classically, gestational diabetes mellitus is usually diagnosed after 24 weeks of pregnancy, most commonly during 24 to 28 weeks of pregnancy, because at that time the placental hormones get high and insulin resistance is developed and hyperglycemia happens. But in many women may have pre-existing diabetes and pre-diabetes, because as Dr. Tasbir already said, that more than 55% of our population do not know that they have diabetes or not. And in our country, pre-conception checkup and pre-conception monitoring on tests are not still there in our country. So many of our women do not know that they have any pre-diabetes or diabetes, and they can develop hyperglycemia earlier in pregnancy before 24 weeks. Let's just recapitulate about glucose regulation, how it happens in pregnancy. Why GDM is usually detected after 24 weeks? Because during early gestation, actually insulin sensitivity increases, and that leads to normoglycemia to promote the uptake of glucose into the adipose tissues of the mother. But later, as the weeks goes on, then the local and placental hormones like estrogen, progesterone, leptin, cortisol, human placental lactogen, placental growth hormone, human chorion, gonadotrophin, these hormones all together go up and they develop insulin resistance. And at the same time, pancreatic beta cell dysfunction happens due to a chronic condition of insulin resistance. And later, after 24 weeks of pregnancy, the hyperglycemia glucose level increases in the blood. And this is just, I don't want to waste time here, because we know that high blood glucose or hyperglycemia stimulates beta cell to secrete more insulin. And when there is insulin resistance, there is more hyperinsulinemia. And there is a secretion of various hormones from placenta, which leads to this insulin resistance. And this hyperglycemia leads to the fetus to uptake more glucose, and ultimately the complications results in the fetus. What are the risk factors of developing GDM? Number 5 is very important, ethnicity. As Asian, we are already in high risk group. we know that in the Asian women are introduced as a high risk group for developing GDM. So we are already have a high risk, that is we are Asian, and also very rising concern that overweight or obesity, that is high BMI during pregnancy leads to increased risk of GDM, developing GDM. Later age at childbearing increases the risk of developing GDM, especially after 25 years or 30 years. Previous history of gestational diabetes mellitus, family history of type 2 diabetes mellitus, and some hormonal issues like polycystic ovarian disease. These women have increased risk of developing GDM during their pregnancies. Gestational diabetes mellitus, if we cannot properly manage, then many maternal and fetal complications may develop. And these complications may be short-term, which can be seen during pregnancy and during delivery or after delivery, but some may be even long-term, which can happen throughout our life, both in the mother and fetus. The short-term maternal complications, most important is hypertensive disorders in pregnancy, which may lead to preeclampsia. There is failure to progress in labor. There is increased risk of instrumental delivery and cesarean section and preterm delivery. But in long term, these women have the increased risk of recurrent gestational diabetes mellitus in their subsequent pregnancies. GDM women have more than 50% chance of developing type 2 diabetes rather than other people, other women. And they also may have increased risk of cardiovascular disease in their life. And fetal complication, short-term fetal complication is there may be IUD or perinatal death is very important. Macrosomia may happen or large for gestational age, which may lead to shoulder dystocia and other related birth injuries. After birth, neonatal hypoglycemia, hyperbilirubinemia, hypocalcemia, these things may happen. But most importantly, the offsprings of GDM mothers have increased risk of developing obesity, metabolic syndrome, type 2 diabetes, and the female or daughters may have GDM in their lifetime. So this condition, which are happening in the womb, can develop complications throughout their lifetime. So this is very important to prevent GDM. Now, how we can prevent or protect these women for developing GDM and for management of good glucose control. According to ACOG committee opinion, each and every woman should be included in preconception education before conception, and counseling should be done for developing risk of diabetes and consequences of diabetes. And this counseling may start from puberty. And those women who have already diabetes mellitus or pre-diabetes mellitus or history of GDM before delivery, they should receive interprofessional care before conception. So pre-conception counseling is very important part of management, which we miss in our country most of the cases, because most of the pregnancies in our country are unplanned. What should we do during this pre-conception counseling, especially if the patient has already DM or pre-diabetes or history of GDM before? Pre-conception education should include weight management, nutritional deficiency correction, nutritional plan, meal plan, caffeine intake and other smoking, regular moderate exercise, and about especially adequate sleep. A supplement of folic acid 400 to 800 milligram and 150 microgram of potassium iodide can be started before pregnancy. And if the woman has already diabetes mellitus or pre-diabetes mellitus, so evaluation of comorbidities and complications like hypertension, fatty liver, PCOS, thyroid dysfunction, retinopathy, nephropathy, any infection, this should be done during the pre-conception counseling, and immunization status should be evaluated. So these things we can do before pregnancy. The pre-conception glycemic goal is HbA1c should be less than 6.5% if the women already has diabetes, and this corresponds to preprandial 6.1 and postprandial less than 8.6 millimole per liter. And using therapy, we should start to use therapies approved safe for pregnancy before conception. If the woman is taking sulfonylurea drug or any drug which are not safe during pregnancy, we should stop that before pregnancy, at least 2 to 3 months before pregnancy, and try to achieve the goal of HbA1c. And review the harmful drugs, like whether the patient is taking ACE inhibitors, ARBs, statins, or GLP-1 agonists. These should be stopped before pregnancy. And we should test HbA1c, creatinine, albumin creatinine ratio, and do an eye examination before pregnancy. And when the person becomes pregnant, then how we should screen the hyperglycemia in pregnancy. You know that Bangladesh government DG office and the endocrine societies and the other stakeholders, they have developed a guideline for diabetes management, and the 5th chapter is gestational diabetes management. And this chapter, according to this chapter, all women should be tested for diabetes or pre-diabetes during planning any pregnancy, if it is possible or feasible. Many of our women are now going to the gynecologists and obstetricians to consult that I want baby and I want to become pregnant. What should we do? So we should test for diabetes or pre-diabetes if possible or if feasible for that women. If preconception test is not done or it is negative, all women should be tested at the first antenatal visit with 3 samples 75-gram OGTT. It is said that high-risk women should be tested during first antenatal visit, but as our ethnicity and our weight and other things, we are already in the high-risk group, so we can offer a test in first antenatal visit. And if not done, again, screening should be done at 24 to 28 weeks of gestation with 3 sample OGTT. Now, different societies have different diagnostic criteria for gestational diabetes mellitus, but more or less they are same except NICE guideline. According to WHO, American Diabetic Association, ACOG and IADPSG, all are almost same, that fasting blood plasma glucose if equal to or more than 5.1, after 1 hour load of glucose equal to or more than 10, and 2 hours after glucose equal to or more than 8.5 millimole per liter should be said as the patient has GDM or gestational diabetes mellitus. Now come to the management. The screening is done, counseling is done, and how we should manage this gestational diabetic mellitus patient. The goal of our treatment should be to achieve normoglycemia, but without any hypoglycemia. Prevention of ketosis, adequate maternal weight gain, and adequate fetal growth should be assured. So the management should be in with a teamwork between the obstetrician and gynecologist, endocrinologist, nutritionist, health educator, and after birth, a good neonatologist. And this is the chart from Bangladesh diabetes guideline. It had been developed. I was the part of development of this chapter, and it has been developed with the help of American Diabetic Association, South Asian Federation of Endocrine Society guideline, and other guidelines. They are combined treatment. They are combined guidance, and this, according to this guideline, if initially during the first test, if the fasting plasma glucose is between 5.1 to 6 and 2 hour plasma glucose 6.7 to 7.8, then try lifestyle modification for at least 1 week with nutritional management and exercise. If target is achieved, we can continue the lifestyle and just monitor every month or every 15 days. But if the target is not achieved, then we should start pharmacological treatment. And in the middle, if the fasting plasma glucose is a bit high, like 6.1 to 7, and 2 hours after glucose is 7.8 to 11.1, do not wait more than 3 days. We can try only lifestyle modification for 3 days. If target is achieved, continue lifestyle and monitoring. If target is not achieved, straightly go to pharmacological treatment. But if if fasting plasma glucose is more than 7 or equal to 7 and 2 hour plasma glucose is equal to or more than 11.1, do not try only lifestyle modifications. Start pharmacological treatment as well as lifestyle modification from the very beginning. This is very easy to teach our junior doctors, that just how much we can wait with lifestyle modification and how much we can do before going to pharmacological treatment. Now come to lifestyle modification. The most important part is medical nutrition therapy, which should be started soon after diagnosis, and preferably we can take help of dietitian to calculate the calories. The calorie allocation during first trimester is 25 to 35 kilocalorie per kg per day, but later it should be increased to 30 to 40 kilocalorie per kg per day. And meal pattern should be at least 6 meals, 3 main meals and 3 snacks, including a bedtime snack to prevent night ketonuria. We know that in gestational diabetes mellitus, there is increased chance of ketonuria, especially in the late morning, early morning or late night. And do not cut all carbohydrate, because it is said that 35% of a 2000 calorie diet should come from carbohydrate to prevent ketosis, and 71 gram protein should be added, and at least 28 gram fiber is needed for healthy pregnancies. What about physical activity? Many of our patients ask that whether I can do exercise during pregnancy. Yes, if there is no contraindication like early gestational bleeding or like that, anyone can do exercise like walking, any aerobic exercise or resistance exercise which are safe. And exercise should be done at least 20 to 30 minutes per day. We can divide it by 10 minutes for 3 times a day. At least 2 to 7 days of per week should we give for exercise. Now come to pharmacotherapy. If the blood glucose values in a total week is above 30% of the blood glucose values are above the target, then do not wait anymore with lifestyle modification, because each and every day is very important in gestational diabetes. And pharmacotherapy should be started. The safest and best treatment is insulin, and we should use both bolus and basal insulin to control the fasting glucose, and bolus insulin to control the postprandial glucose. As bolus insulin, we can use regular insulin, rapid-acting analogs like Aspart or Lispro, and as basal, NPH, Detamid, and Glargine are recommended. Metformin and glibenclamide or glyburide are used in many countries still now, but we will talk later that how much safe are they. Short-acting human insulin are used to improve the postprandial excursions. In many cases, fasting glucose is normal, but after meal are rising. It is very common in GDM, so we can start with short-acting human insulin, which improves the postprandial excursions. It does not cross placenta and it is safe. Rapid-acting analog have less hypoglycemia. Aspart and Lispro are recommended during pregnancy. They are investigated and safe. They have minimal transfer across the placenta, and there is no evidence of teratogenesis. And the advantage is that Aspart and Lispro cause less hypoglycemia. When fasting is more than the target, then we should start basal insulin. NPH, Glargine, Detamid, or Degludec, any basal insulin can be used. But the data of Degludec is still limited. It is a new insulin, but it is emerging. Emerging evidences are coming out. Glargine showed non-inferiority and no adverse outcome. And for first time, ADA, American Diabetes Association, has included Glargine safe for pregnancy in their guideline. And unfortunately, Detamid is being removed from the market, and we will not get Detamid anymore next year or further years. What will be the dose of insulin? The dose depends on the pregnancy weight. The required daily dose may be, it is variable according to the blood glucose levels. It may be between 0.7 to 2 units per kg. Usually 0.7 unit per kg up to 12 weeks is enough. Then 13 to 26 weeks, it comes to 0.8 unit per kg, then 0.9 unit per kg. And later, after 34 weeks or 36 weeks, it is often seen that 1 unit per kg is needed to control blood glucose. And insulin requirements increase with pregnancy progression, because after 16 weeks, insulin resistance increases sharply, and then the insulin requirements also goes high. And women with obesity and multiple gestation may need higher doses, and treatment should be rated to reach the targets, and we should closely monitor these patients, preferably twice in a month to control the blood glucose and to achieve the target, and should adjust the insulin as accordingly. Which regimen is best? Actually, multiple dose of basal bolus is very preferred. 3 times bolus insulin and 1 time basal insulin. This is the best regimen for gestational diabetes mellitus, because we want very tight control and stringent control in gestational diabetes. Pre-mixed cannot achieve this type of control, so pre-mixed is not usually preferred. continuous subcutaneous insulin infusion or automatic insulin delivery. These things are now coming and also available in Bangladesh, but in very expensive, but this can be offered if patient can afford. What about oral anti-diabetic agent? It is a very common question from our juniors that can we use metformin or glibenclamide or glyburide because they are used in many countries. But insulin is the preferred treatment according to Standard of Diabetes Care American Diabetic Association guideline. The most recent one has been published last week, 2026. They are saying that metformin and glyburide should not be used as first-line agent because both drugs can cross placenta, and most importantly, these drugs are not sufficient to achieve glycemic control. Ultimately, we need to shift to insulin, so why start with these drugs? And metformin, often these women are already taking metformin for treatment of PCOS or other things, and according to ADA, metformin should be discontinued by the end of first trimester, and patients should be switched to insulin at that time. Metformin has some advantages. Metformin causes less weight gain, decreased risk of macrosomia, decreased risk of neonatal hypoglycemia, and less risk of pregnancy-induced hypertension. But in long-term studies, which have been done for about 15 years after birth of the offspring, they have shown that there is increased chance of BMI and obesity, increased offspring BMI and obesity in mid-childhood, in those babies whose mother have taken metformin. And there may be less gestational weight gain and decreased birth weight if the mother is taking metformin. Glibenclamide or glyburide has many disadvantages, like they increases the risk of macrosomia, increases the risk of neonatal hypoglycemia and other problems. But both drugs are not associated with congenital anomalies, and both drugs can cause cross placenta with unknown consequences in the life of offspring. So we should not take the risk, and insulin is the best choice during pregnancy. The glycemic goals are different from normal diabetes. As already Dr. Tasbih said, that is very stringent control is needed in during pregnancy. Fasting blood glucose should be between 3.9 to 5.3 millimole per liter. 1 hour after meal, 6.1 to 7.8 millimole per liter, and 2 hours after meal should be between 5.6 to 6.7 millimole per liter. And this target achievement is very important in every day, every week, every month. And this should be achieved by avoiding hypoglycemia, because hypoglycemia also increases the risk of many complications. And do not try to reduce blood glucose less than 4.8 because it has no benefit, and more there is increased risk of growth restriction. So don't try to restrict less than 4 or 4.8. Try to take it between 5 and 6. This is best. This is the best. Should we use HbA1c test to monitor glycemic status in pregnancy? We know that HbA1c presents the last 3 months, 120 days average diabetes. So we are more reliable monitoring is every day or every alternate day self-glucose monitoring, because HbA1c will change will take at least 2 to 3 months to have a change. And also there is increased red cell turnover in pregnancy and anemia. So HbA1c may seem lower than other people during pregnancy. But ideally, if we do HbA1c, it should be less than 6% in each trimester. And just as I have already said that do not do any hypoglycemia in prick blood less than 3.9 millimole per liter, or sensor blood less than 3.5 is called hypoglycemia. So we should avoid hypoglycemia during pregnancy. What will be the goal of achieving weight? Recommended weight gain during pregnancy, if the woman is overweight, the total weight gain should be between 6.8 to 11.3 kg. But in case of obesity, we can do less weight gain, like 4.5 to 9.1 kg during the pregnancy. And losing weight or too much diet control is not recommended because of increased risk of short for gestational age baby. How we can monitor during pregnancy? The best is intermittent self-monitoring of blood glucose. For this, good health education is very important. Whenever we diagnose a GDM case, at that time, we should ask her to buy a glucometer, a good quality glucometer. We should teach them how to monitor herself, the glucose by the glucometers, and how to maintain the chart. This is very important. And we can do HbA1c in each trimester and continuous glucose monitoring. This is also available in our country now, and it is increasingly used by pregnant women because it is more convenient. You don't want to prick you 4 times or 6 times every day if you can use CGM. And self-monitoring blood glucose at least every alternate day or twice in a week. Ask the patient to maintain a chart by doing self-monitoring blood glucose. Ask to do before breakfast, that is fasting, and at 1 hour or at least once after 2 hours after the beginning of each meal, that after breakfast or after lunch and after dinner. And write it down in a chart. And when you go to your doctor, bring that chart with you. And this is very important because self-monitoring blood glucose will guide us how we can adjust our insulin dose. As I have already said, HbA1c target during each trimester is less than 6%, but there are some fallacies. Increased red cell turnover, increased blood volume, anemia. These things can make HbA1c to seem lower. So it is not the primary measure. It should be used as secondary measure. Continuous glucose monitor. This woman has a CGM machine on her right arm. It is very convenient because you don't need to prick multiple times if you have a CGM on your body. And what will be the goal? This continuous monitoring comes to your mobile phone, and the goal sensor glucose range is 3.5 to 7.8 millimole per liter, and total insulin target should be, the goal should be more than 70%. It will be seen in the chart. For preeclampsia, increased risk of preeclampsia, according to ADA, they have said that pregnancy with type 1 or type 2 DM should be prescribed low-dose aspirin, 100 milligram at least per day. A dose of 162 milligram is also acceptable. Unfortunately, we in our country, we have 75 milligram aspirin. We don't have 100 milligram aspirin dose. So if we can use 2 tablets daily, that will make nearly 162 milligram per day. And it should be started at 12 to 16 weeks of pregnancy. And it will reduce the risk of preeclampsia and other complications. During labor, hospital delivery is mandatory if the woman has GDM. But indications of cesarean section are the same as other women. Diabetes mellitus itself is not indication of cesarean section. The patient can have normal labor and normal delivery if everything is well controlled. During labor, maternal blood glucose should be between 4 to 7 millimole per liter because there is high chance of diabetic ketoacidosis if there is increased blood glucose during labor. And labor is a very strenuous hours, and this may lead to ketoacidosis. And whether we should continue insulin during labor depends upon the requirement of insulin. If women who require less than 1 unit per kg per day insulin can simply be monitored without any IV infusion, we can just monitor during the labor or during surgery. But if blood glucose is high, then infusion 5% dextrose with short-acting insulin can be started. But remember to stop just after placental removal, because when you remove the placenta, the blood glucose will drop down, and all the placental hormones will drop down, and blood glucose will also drop down, and there may be hypoglycemia if we continue insulin at that time. So we should stop the infusion immediately after delivery. And the blood glucose of newborn should be checked by heel prick within half an hour because there is increased risk of neonatal hypoglycemia, and then neonatologist or nurse will take care of that. Postpartum management is the very poorly managed in our country, because after the birth of the baby, this lady never come back to obstetrician or endocrinologist. They go home and they are very happy with their child, but they do not come for follow-up. But just we want to inform her before delivery that the history of gestational diabetes has lifetime increased risk of developing diabetes, when it is 50 to 60%. That is 10 times more in comparison to others. So this patient should be monitored later in life. Obesity, increased gestational requirement of insulin, and early gestational age at the time of diagnosis, all these increases the risk. And women with GDM should be screened at 4 to 12 weeks postpartum, then annually. Usually, when the time of the first vaccination is 6 weeks in our country. So during that 6 weeks, we can ask the patient to come back to hospital for again do an OGTT and mark this OGTT result may be normal or pre-diabetes or diabetes. If it is normal, then just ask her to maintain her lifestyle modification and maintain her weight and regular monitoring annually. If pre-diabetes, then we can strengthen the lifestyle modification. And if diabetes, then we should do the pharmacological treatment. And insulin should be used during lactation, because insulin, because all the oral drugs can be secreted in the breast milk, and they may cause hypoglycemia in the infants. So these are the sources from where I have taken the informations, and I don't want to lengthen my talk, because this is the main principal things that should be known to all gynecologists and all general physicians, that when a pregnant woman is diagnosed to have GDM, when to screen her, when to refer her to endocrinologist or gynecologist, and when to start insulin or pharmacological therapy, and how to monitor. These things are the main basic things that we should remember. We don't want to make it complicated. Just we want that throughout the country, even in the villages, everybody can follow these guidelines. And as I have told, thank you very much, and thank you all for your patient hearing.
Thank you very much, Dr. Tanzina Madam, for your excellent presentation and very much easy presentation to understand for all of us. We have the foreign delegate from UK and Pakistan also. We also hear from them from their country's protocol. Before going that, I'm requesting Professor Roshanara Begum for your comments regarding the presentation of Dr. Tanzina. For the short comment, Madam.
Thank you, Dr. Sharmin. At first, I must thank you for your excellent choice of this subject. And I welcome to the Professor Rubina, and also from the UK, Dr. Bukit. And thanks to the Dr. Tanzina. Thank you, Dr. Tanzina, for your excellent and informative lecture. The presentation clearly highlighted the recent updates in the management of diabetes in pregnancy and translated evolving evidence into practical clinical guidance. I particularly appreciated the structured approach to early screening and diagnosis, the emphasis on individualized glycemic targets, and the clear explanation of current insulin strategies and the selective role of oral agents. The discussions on the continuous glucose monitoring and patient-centered care was especially relevant in today's practice. Overall, this was a well-balanced, up-to-date, and clinically useful presentation. I congratulate the speaker for an excellent lecture and thank her for enriching our understanding of this important topic. And I also welcome now the next panelist. Thank you, Dr. Shah.
Thank you very much, Madam. We have the expert discussion today. First of all, I want to go to Professor Maliha Rashid, Madam, in our country perspective, Madam. I want to know from you.
Slide off.
হ্যাঁ, তানজিন আপা একটু স্লাইডটা অফ করেন। ম্যাডাম, কিছু পেশেন্ট আছে যাদের হচ্ছে ডায়াবেটিস আগে থেকে আছে, তার এখন প্রেগনেন্সি হয়েছে, আর কিছু হচ্ছে নিউলি ডায়াগনোসড হচ্ছে ডায়াবেটিস ডিউরিং প্রেগনেন্সি। ম্যাডাম, ডেলিভারি প্ল্যানটা ম্যাডাম কেমন হবে? দুজনের ক্ষেত্রে কি সেম হবে নাকি এখানে কিছু ডিফার করবে? আর পিউপেরিয়ামে অ্যাকচুয়ালি আপনি কি প্রিন্সিপাল আমাদেরকে ফলো করতে বলবেন এই ধরনের পেশেন্টগুলোকে ফলো আপ করার জন্য? ওভার টু ইউ, মালিহা ম্যাডাম।
Thank you very much, Dr. Sharmin, for the excellent question. Actually, আমরা দু ধরনের পেশেন্ট পাই। আমি কি বাংলায় বলবো?
ম্যাডাম মিলায় বলেন, রুবিনা সোহেল।
Ravina is here. So the question was in Bangla. So two types of patients we usually get in our day-to-day practice. Number one, gestational diabetes mellitus and GDM, যেটাকে আমরা GDM বলে থাকি, এবং actually full-blown diabetes mellitus with pregnancy. Now, those patients who are diagnosed during pregnancy due to the insulin resistance, actually they are the GDM cases. When the GDM cases, we deal with the GDM cases, and the diabetes is controlled by lifestyle modification and diet, they should be, the delivery plan should be like normal one. That is, we can wait up to 40 weeks, even 41 weeks of pregnancy, if everything is all right. That is, if the maternal and fetal well-beings are good and there is no contraindications except this factor to continue the pregnancy. And when the diabetes is not controlled, that is with the diet and the lifestyle modification, and they need some pharmacological therapy, then it is better to, and the diabetes remains always controlled, it is better to deliver her between 39 weeks of pregnancy, and will not allow them to go post-dated. And when the blood sugar is not controlled, that is, she is not well controlled with the drug, then it is better to terminate the pregnancy when the fetal maturity is occurred, that is after 37 to 38 weeks. And by this time, the 37 to 38 weeks, usually due to the maternal and fetal risk, and the delivery, if there is no contraindications for normal delivery, that is normal delivery, maternal or fetal indications, like maternal indications like she is complicated with other drugs, that is diseases, that is comorbidities, then maybe she may have pregnancy associated some problems like placenta, low-lying placenta, like transverse, like macrosemic baby, like IUGR and compromised baby. In those cases, cesarean section can be done.
Yeah.
Otherwise, it is better to allow her to go into normal delivery or
Yes.
induction of labor.
Madam, any role of giving routine steroid to them for the lung maturation of the baby? Do you think it is used in routinely or selective cases?
No, it is when the delivery is, we continue the pregnancy up to that term, that is up to 40 weeks, when the diabetes is well controlled. I think
Yes.
there is no requirement of steroids, but when early termination is required, it is we should give her the steroids. Yeah. Now, how the delivery will occur? The delivery may be normal delivery if the patient is glycemia is controlled, well controlled. She need not to have the insulin throughout the labor process. But if it is not controlled, then continuous glucose monitoring along with the glucose infusion can be given according to the need of the patient, and she should be monitored whether she is going to hypoglycemic or not. And regarding anesthesia, she may have epidural anesthesia at the time of delivery, and low forceps or ventrose delivery can be done. But when cesarean section is required for the maternal or the fetal indications, on that cases, the lady who is getting insulin, she should not have the morning insulin dose, and she will have she will check for the blood sugar level, and her sugar will be maintained by intravenous insulin, by infusion pump or direct. And after cesarean section, after delivery or cesarean section, the blood sugar level usually comes down, and at that time the blood sugar should be monitored immediately after the delivery of the baby. If usually the blood sugar level, she needs insulin level, insulin requirement is lower at that time, yeah. And those patients who did not require insulin before during pregnancy, she'll not require insulin at that time also. But those patients who required insulin during pregnancy needs to modify the insulin. Usually the dose is reduced, half of the dose which she was getting during pregnancy, and the dose is monitored, given according to the demand of the patient. So, and this is the delivery chapter.
Yes,
And after delivery, postpartum period, she should monitor the blood sugar after 6 weeks. Who are not diabetic, she will have a full range of oral OZTT, and those patients who was getting insulin should get continued insulin up to the postpartum period. Yeah. And the baby should be managed meticulously. The delivery should be done in the place where 24 hours neonatal care is available. Blood sugar of the baby should be done half an hour after birth, then 2 hours, 4 hours, 6 hours after birth. And if the blood sugar level is lower down and below 2 millimole per liter, in that time, for after successive 2 sessions of breastfeeding, if it does not raise, at that time IV or oral glucose treatment should be given. And this baby should be examination for the polycythemia, for hypocalcemia, for hypoglycemia, and hypomagnesemia should be tested. And like this, and throughout the life, we should remember the baby is at risk of developing diabetes at any time of his life, and he or she should be aware about this to the parents. That is, parents should be aware the baby is at risk of
yes, madam.
diabetes in the later life. So
Thank
they take care so that the baby is not overweight or obese. And
Thank you, madam.
yes, thank you very much.
Thank you, madam, for your fantastic guideline. It's actually very much simple, but the people should follow it and the young doctors should follow it to manage this sort of patient. Thank you. And now we will want to know about the Pakistan protocol from the Rubina Sohel madam, the Honorable Past President of the SAFOC. Madam, we heard from Dr. Tanzina and our Honorable Professor Maliha Rashid about the Bangladesh protocol. So any difference in the Pakistan protocol to manage this sort of case? We want to hear from you, Professor Rubina Sohel ma'am.
Thank you very much for giving me this opportunity and looking at our Pakistan perspective as well. I have just tried to, so most of the things that have been mentioned over here today are the ones which Pakistan is also following. But I feel that when we are talking about diabetes, we sometimes cross the boundary between gestational diabetes and diabetes mellitus. And I would just like to point out a little bit from Pakistan perspective, and then I would like to talk about what I think should be done and what we are trying to do in Pakistan as well. So I would just like to point out for the audience that Pakistan has got a high rate of gestational diabetes, sometimes going up to 57% in pregnancy. And this is huge. And the province which has got the maximum gestational diabetes is Balochistan, followed by Islamabad, and then the other provinces have got gestational diabetes happening in them. Now, we are following the SOGP guideline, and obviously SOGP guideline, like Bangladesh guideline and other guidelines, is an essence of the international guidelines and what they are doing internationally. So the SOGP guideline, then the Pakistan Endocrine Society guidelines, and there are PROMPT. PROMPT is the Pakistan recommendations for optimal management of diabetes from primary to tertiary care center. So PROMPT basically tells us that if the woman is presenting at the primary care center, what is it that the physician should be doing? When they present at the district headquarter hospital, what is it that we should do? And in a tertiary care center, what should be done? So we do recommend oral glucose tolerance test, which is a 2-hour test of 75-gram oral glucose tolerance test between 24 and 28 weeks of gestation for all pregnant women, irrespective of the risk that they are going to face. So South Asian women are considered to be high risk, so we will do it in everyone. Women who have got previous history of gestational diabetes are generally recommended, or other high risk factors can go for glucose tolerance test in the first trimester of pregnancy as well. But as you do understand that in the first trimester, there's a lot of nausea and vomiting, and sometimes women find it very difficult to carry out the oral glucose tolerance test in the first trimester. The third thing we are doing is that we do not let these women alone after they deliver. So we recommend oral glucose tolerance test 4 to 12 weeks postpartum. So some of the guidelines do recommend a blood sugar fasting level, but I feel that blood sugar fasting is appropriate for patients with diabetes mellitus, but not with gestational diabetes, because in gestational diabetes, the blood sugar fasting mostly is not raised significantly, so there's no point in testing the blood sugar fasting level. And if these women develop gestational diabetes, they are recommended lifelong screening every 3 years for diabetes. This is what we are doing in Pakistan, and we are following the standards of Diabetes Care 2024. The second thing I want to point out from especially Pakistan perspective is that in Pakistan, about 14% of the population is underweight. But what about the rest of the population? 25% overweight population, 15% obese population. What does that mean for us? It means that 40% of the women who will start the pregnancy will be either overweight or obese. So that puts them at an additional risk, because if they continue to eat the way they were eating to maintain this weight, then the probability of gestational diabetes will increase. So we counsel our women, because evidence is available and there are studies available which say that women who gain a lot of weight in the first trimester of pregnancy are at 80% risk of gestational diabetes. So to me, the first trimester is the trimester where we should be watching the weight gain and the kind of diet that women are eating. So in the first trimester, when women come to us for their first visit, this is an opportunity to talk to them about their physical activity, because you know that India and Pakistan and Bangladesh and all this, the belt of South Asia, what is happening when women become pregnant, most of the mothers are going to say, you are pregnant, you need to relax and rest and eat. So what does that do for the poor women is that it increases the weight a lot, and they then become gestational diabetes later on. So I think this is something that we are trying to follow and making sure. The third thing that we focus on is the long-term consequences for the mother and the baby of gestational diabetic mothers. Obviously, greater probability of developing type 2 diabetes, cardiovascular disease, high risk of malignancy, and long-term renal morbidity. These are all the things which we are concerned about. But we are also counseling the women and concerned about the offspring, because there's a 5 times greater probability in the offspring that they will become glucose intolerant. They have a probability of obesity, endocrine morbidity, cardiovascular morbidity, neurodevelopmental outcome, poor, and ophthalmic disease. So we do talk to them about these things as well. Now, just a couple of points that I want to make regarding gestational diabetes. I respected the talk of the previous speaker, and I really liked what she said, and very appropriate points were made. But I want to say something from the perspective of trainees, if they are listening, and from the perspective of young gynecologists. You know, since the time we have started following the guidelines, we always talk of multidisciplinary approach. I don't, I'm not saying that I'm not in favor of the multidisciplinary approach, but I'm saying that when we start talking about multidisciplinary approach, sometimes our trainees stop focusing on the disease management themselves, because they feel that if they diagnose gestational diabetes, they're going to ask the endocrinologist to manage the diabetes. So the point that I'm trying to make is that we gynecologists and obstetricians need to be able to manage all these high risk conditions ourselves as well, and take advice and opinion as and when the need arises, not to refer the patient immediately to the endocrinologist as soon as we diagnose that the woman is diabetic. So it is the responsibility of the OBGYN professionals to know how to control a patient of gestational diabetes well. So what does it entail? It entails counseling them about weight gain. It entails counseling them about the diet that a diabetic needs to take. It entails initiating insulin. So to me, the most popular insulin is long-acting insulin, It comes with the name of Levemir in Pakistan. So long-acting and ultra-short-acting insulin, I think, should be the drugs of choice. The cost is a little bit of an issue. So in government hospitals, sometimes long-acting insulin is not really available. But as we keep on telling our surgical and medical colleagues that if the government hospitals can afford to buy all the medical medications, which are pretty expensive, then they could afford insulin as well. The third thing is that we have a very high cesarean section rate in South Asia. So, non-communicable disease is an issue of our region. Now, what we are doing is that we sometimes use diabetes, pregnancy-induced hypertension, cholestasis of pregnancy, and so many other conditions as a reason to induce labor. What I'm trying to say is that if diabetes is well controlled, if there is no macrosomia, if the blood sugar is normal and has remained normal in pregnancy, then there is no indication, as Madam Roshanar also said, that there is no indication for induction of labor in gestational diabetes. The indication for induction of labor is in diabetes mellitus, not in gestational diabetes. So a well-controlled gestational diabetes can actually safely go till 40 and 41 weeks of pregnancy because the renal changes have not taken place, which would happen in diabetes mellitus. In diabetes mellitus, the vasculature is affected. So in diabetes mellitus, the circulation is affected. And that is why in diabetes mellitus, we sometimes induce our patients to deliver them before 40 weeks, and I respect that. But one of the ways of reducing unnecessary cesarean section is reducing these unnecessary inductions that we are doing for gestational diabetes for other conditions as well. And one of the last things is that postnatally, do not let the woman alone because these are the women with gestational diabetes who will become diabetic and come back to us in the next pregnancy with diabetes at 6 weeks of pregnancy. So we have to make sure we keep on counseling them, we keep on monitoring them postnatally, get their glucose tolerance test done in time and follow them up. I will stop over here because I'm sure people would like to ask questions. Thank you so much.
Yes, madam, there are many questions in the chat box. We'll take it later on. Thank you very much for giving
Excellent.
us the protocol of Pakistan. But I have a question
Thank
to
you.
you. Are you using
Yeah.
metformin in Pakistan during pregnancy?
Okay, so this is a debatable point for Pakistan. So our guidelines do recommend metformin, but metformin has an issue. The issue with metformin is that metformin does not allow the fetal weight gain to happen as it would happen if the woman was not taking metformin. So it restricts the weight gain of the baby in pregnancy. The second thing is that metformin is not the favorite drug of a lot of women. So they feel that there is diarrhea, there is abdominal cramping, they are going to miss the tablets. So if we are looking at good diabetic control, then should be the drug of choice rather than metformin. So it is not yet changed in our guideline, but we are on our way towards there. But my personal opinion, obviously, is that insulin should be preferred. Now, obviously, it is the patient's right, the era of patient's rights. So if a patient chooses to take metformin instead of insulin, because some women have fear of insulin and injecting themselves every day, then obviously metformin is also an option.
Thank you very
After
much,
counseling.
madam, for your fantastic opinion. And you are always blessing for us, madam. You join the session and make the session colorful and very informative. Thank you, madam.
Thank you.
I
Thank
want to
you.
hear from Sir Bitat. Sir, I want to hear from you the UK protocol actually management, what Tanzina said, what Dr. Paliha Rashid ma'am said, and last of all, Rubina Sahal ma'am said. So in UK, and you are the prominent endocrinologist who is working in UK and proud Bangladeshi also, sir. We are very much proud of you. So what's your thinking that is there any difference in the management protocol or something new you want to add here that Bangladeshi gynecologists or endocrinologists can adapt to manage it in perfect way? Over to you, sir.
Yeah, thank you. I would like to thank all the panelists and also the chairpersons for giving their precious time for this very important topic that we are discussing today. And also thank you, Dr. Tanzina, for the extensive report, which looks like you're following in Bangladesh. And I have to say, I'm quite impressed that it is almost the thing that we follow here. There are a few differences, isn't it? One thing we mentioned that preconception planning and care is very important in UK. It is done by the primary care. We even if someone have pre-existing diabetes, we tell them not to stop contraception until we have optimization of their diabetes control. So I think that is really important, and that is the thing we should in future we should try to concentrate on in Bangladesh as well. And otherwise, whatever Dr. Tanzina has mentioned is almost the same as what we do in here. From the GDM diagnosis point of view, we do a slightly different, because if someone has a BMI of more than 30, had a previous macroscopic baby or previous gestational diabetes they had, in that case, we check their we do their GDM test at around 24 to 28 weeks. But if someone has previous gestational diabetes, we teach them how to monitor blood sugar at home with capillary blood glucose monitor, so that we can pick it up early. And as soon as we confirm the diagnosis, and the diagnosis wise, we do is 75 gram 2 hour OGTT fasting, and the 2 hour. We do not do the 1 hour in here. So if it's diagnosed straight away, that patient will be booked into the clinic of joint endocrine diabetologist and obstetrician, and from then on, straight away they are going to refer to the dietitian first, and they will have appointment every 1 to 2 weeks in clinic. It could be a diabetes specialist, nurse, and obstetrician. Is sometimes it could be a consultant and consultant obstetrician clinic. So we keep a very close eye on their blood sugar, and we have a cloud system, because nowadays where they can put their data on the cloud, and diabetes specialist nurse and dietitian can review those data and phone them and try to titrate their insulin, metformin. So we have very good system. I think in future, maybe in Bangladesh, we can think of developing it as well. Otherwise, if we look into the diagnosis wise, the level of fasting is 5.6. It's a bit different from the other country. And what other thing we do is different. We always try to give an individualized plan. We do not try to fix on a numbers, trying to get it there. And so also we need to make sure the patient does not develop hypoglycemia. So it's always individualized care plan that we concentrate on in here. And as Dr. Tanzina mentioned, that I'm not sure whether we're using continuous glucose monitor or freestyle or flash glucose monitoring device in Bangladesh or not, but most likely it is we are getting there in Bangladesh as well. So we offer this kind of device only for type 1 diabetes, and sometimes to type 2 diabetes who are on more than 2 insulin, especially if they are on short-acting insulin. So we give this device to them. Otherwise, for the GDM patient, usually it is a finger pricking capillary blood glucose test. HbA1c, we do not do HbA1c during the pregnancy to monitor the blood sugar profile. It's always the capillary blood glucose or CGM. And HbA1c sometimes we can do to stratify the risk, especially in that the booking. During the booking appointment, the first appointment, we do the HbA1c for type 1 and type 2 pre-existing diabetes patient. And if we think sometimes GDM patient may have a undiagnosed type 2 diabetes, in that case we check their HbA1c. Another thing, what I have noted in the GDM investigation for Bangladesh, and I really appreciate that we are doing it for. I think we should do it for everyone, because in UK, when you have some ethnicity, they recommended to do their GDM based on that, and that ethnicity is us, so it's a South Asian. So we have to. So that means in every South Asian in UK gets a GDM testing. Yes. And if we move on, type 1 is the one I definitely think should be managed by type 1, and type 2 as well should be managed by a diabetologist. Yes, as Dr. Rubina as well has mentioned, here in UK, obstetricians are capable of managing GDM. So they do manage GDM. Yeah, most of the time they do not try to get involved if it's type 1 or type 2, but that's understandable as well. And from our point of view, the managing diabetes during pregnancy is always should be with insulin, metformin, as Dr. Tanzina mentioned. And I do not think we for the ketones, I think we do not give ketones strip if someone has GDM and even type 2. Usually ketone testing is recommended in UK for someone who has type 1 diabetes and with high CVG if the patient. But if they come to hospital unwell, then we do check their ketones in GDM patient and type 2 patient as well. And one other thing I think we should think about is the retinal assessment during pregnancy. So it is also important, and I do not think if someone has diabetic retinopathy, it should be considered a contraindication for optimization of blood glucose, because we can understand that we need a rapid optimization during pregnancy. And if someone has diabetic retinopathy, it should not be contraindication for vaginal delivery as well. And so in UK, we do retinal assessment by digital imaging during the booking if it's not been done in the last 3 months. If it does not show any retinopathy, patient is not offered anything. But if it shows a background retinopathy, patient will have another one in 16 to 20 weeks and another at 28 weeks. But if it shows pre-proliferative or proliferative retinopathy, they will going to get more appointment from the ophthalmologist.
Yes.
And the renal one is usually, as Dr. Tanzina mentioned, here we check creatinine, ACR during the booking appointment, and also during the preconception. And we do refer this kind of. There are some referral criteria to the nephrologist, like if the serum creatinine is more than 1.3, ACR is greater than 30, then we do refer this patient to the nephrologist. And if they have very nephrotic range proteinuria, they are given the thromboprophylaxis in UK. Otherwise, Dr. Tanzina has spoken about preeclampsia. That is fine. I think we follow the same. And about detecting congenital malformation, usually patient with diabetes or GDM has an ultrasound scan in the 20 weeks to detect fetal structural abnormalities. And that is what was offered in here. And I'm not sure what's the protocol in Bangladesh, but everyone must have some protocol in Bangladesh as well. And we offer pregnant women with diabetes ultrasound monitoring of fetal growth and amniotic fluid volume every 4 weeks from 28 to 36 weeks. So that's pretty standard for patient with diabetes and GDM in UK. So we do that. And otherwise, as I mentioned, it's quite a long journey, isn't it? There's a lot of topic to discuss.
Yes.
And the GDM, usually after GDM, we repeat the fasting blood sugar in UK after 6 weeks. But if it's after 13 weeks, we do HbA1c to make sure that patient did not develop type 2 diabetes. That's what we do here, in short.
Thank you, sir. We have some question. I'm requesting our discussion to give the answer. So first question to Tanzina Appa, that one of our participant asked that how many times hemoglobin A1c should done in whole pregnancy period in diabetes in pregnancy?
Thank you for the question. As I have already said, that hemoglobin A1c may be misleading in pregnancy, actually, because there is reduced red cell turnover, there is anemia, and there is some fallacies for doing HbA1c. And HbA1c needs about 120 days to be changed to reflect the glycemic status. So the primary choice is self-monitoring of blood glucose. And HbA1c, as have Dr. Bitat already said, that we can monitor it if we want to see the status or we want to see the risk of complications. And HbA1c is done 3 monthly. So during total pregnancy, at least 3 times or 2 times we can do HbA1c, and it should be less than 6%.
Yes. Thank you. Dr. Beta, would you give answer one participant question? She wants to know that in polycystic ovary syndrome, patient metformin is ongoing, and in ongoing metformin, the patient become pregnant. So should we stop the metformin or continue the metformin because the PCO have a great chance to become diabetic in pregnancy?
So PCOS itself increases the chance of GDM, isn't it? So I think in that case, this patient should be given, especially if they have a high BMI PCOS, they should be given capillary blood glucose monitor to monitor their blood sugar. But in UK, the normal practice we say, because we do endocrine clinic as well, we tell the patient with PCOS to stop the metformin as soon as they fell pregnant. That is the general advice we give here. But saying that, there are some other endocrinologists who tell them you can continue the metformin as well. So it's a kind of a different kind of opinion about the continuing metformin. And in my opinion, I don't think that if you continue metformin, it will do any harm. That's my opinion.
Okay. Rubina ma'am, regarding the MDT approach, what is your opinion? From the beginning, the team should be the MDT group, or the gynecologist is efficient to control it. She will control it. If it's not within her hand, then he will or she will refer. So, what's your opinion?
I think it's a controversial topic, but Dr. Bittard gave a very good answer. And he simplified it for us that if the patient has got gestational diabetes, I think there is no reason that OBGYN professionals should not know how to control diabetes, gestational diabetes. So if a patient had gestational diabetes, I would first try to control it myself, doing counseling, counseling and putting her on medication and then seeing. If I am able to control diabetes, it's fine. If I'm not, then obviously endocrinologist help is very important at that point in time. The patients who are type 1 or type 2 diabetes, that's a totally different cup of tea. And they have a pre-existing condition which might be affecting their different body systems. So for a thorough evaluation and and people who have experience in controlling their blood sugar would know that it is pretty difficult to control blood sugars in patients who are type 1 and 2 diabetics. It's sometimes a challenge. So I would definitely seek early help from an endocrinologist to make sure that it gets controlled earlier on. That would be my strategy.
Thank you.
Thank you.
Dr. Bitter, I don't know why the confusion is arise in the question group. They just want to know if any patient in diet or if any patient on oral hypoglycemic or insulin, the target level of achieving the controlled blood sugar level is same in case of fasting and 2 hours after meal, or it is different, and what will be the best target?
So as I mentioned that the target should be always individualized, all right? So some patient we have always seen, especially let's say type 1, we are going to find it very difficult for type 1 patient to maintain the target at the level we want, because it can cause recurrent hypoglycemia, which we don't want that, because we know that it's harmful for the baby as well. And so it is from our guideline point of view, it is same for GDM type 1 and type 2 diabetes, which Dr. Tanzina has mentioned, and it is the numbers are same almost everywhere. It's not very much different, but we always have to look at the patient perspective and try to individualize the care plan, and that's what we do. Okay.
Okay. One interesting question to Tanzina Madam. Does tight glycemic control truly reduce long-term offspring metabolic disease or only short-term perinatal complication?
Well, I have already said that we don't have that much data about how long this maternal hyperglycemia affects her offspring. But in some European studies, they have followed at least 15 years of the babies, and they have found that the offsprings of GDM mothers, they have increased risk of metabolic syndrome, obesity, overweight, cardiovascular disease, and developing type 2 diabetes. So as much as we can stringently control the blood glucose of mother, so we can reduce the risk, the future risk of these babies. So this is very important. And also, as the maternal hyperglycemia is related to the immediate complications of the baby, like neonatal hypoglycemia, congenital malformations, or macrosomia, IUD, these things. So we need to stop these immediate complications as well. So strict control of maternal hyperglycemia will lead to reduction of the risk of immediate complications and also late complications.
Dr. Bitter, do you want to add anything here, or you are with the same route with Dr. Tanzina?
No, I completely agree with Dr. Tanzina.
Okay, thank you. Maliha ma'am, one interesting question for you. One of our participants want to know that GDM, primarily, what do you define it as a placental disorder or as a early manifestation of maternal metabolic disease or both?
I think it is the early detection of the maternal metabolic disease, not the placental disease only. As because the placenta, every lady should have will have diabetes in pregnancy, but some ladies have got diabetes and others are not. So I think this is the early onset of the metabolic disorders of the pregnancy, metabolic disorders for the mother. I think so. Thank you.
May I add something, Dr. Sharmin?
Yes.
Yes, a very important question is, can we prevent GDM? This is a very important question. If we can increase the awareness among the young women, we have started on behalf of Bangladesh Endocrine Society, we are going to colleges, women's colleges, and trying to understand that there is high risk of GDM in our country. It is one of the highest among the Asian countries. So if the girls can live a healthy lifestyle, if they have a healthy eating pattern or meal pattern, if they do the exercise regularly, if they can maintain their weight or BMI, so they can prevent GDM. That is a huge thing that we are missing. Many of our adolescents and young ladies are obese and they are leading very unhealthy lifestyles.
Last question to all of you, that continuous glucose monitoring used in pregnancy that redefine that optimal glycemic control, what really means?
That's what's in the afternoon. So she could do more around.
I think
So-
Dr. Bitat can answer this very much
I
well
thi- I
because
think-
they are
I
using
think-
it for many years. But in Bangladesh, it is now available, and I have offered few of my patients who can afford, and this gave them comfort and they are not need to prick themselves so many times during their pregnancy. This is a very good thing. What about
I think, as I mentioned here, isn't it? So CGM is now we are using for everyone who has type 1 diabetes. Type 2 diabetes, if they are on short-acting insulin, we'll give it to them. But here, CGM is not used for someone who has GDM. Except very exceptional circumstances, if they have needle phobia, we are using it. The use of CGM for gestational diabetes mellitus, I do not think there is much evidence that it should be followed in. But in future, it may change because there is a new data is always coming up. But at the moment, looking at the data, I do not think there is much data to support that we should use CGM for the GDM. But it works very well for the type 1 diabetes. And it is also helpful for the patient that they do not need to prick like 4 or 5 times in a day to do the capillary blood glucose. And for type 1 and type 2, yeah, definitely it is doing a lot of help. And also CGM we are using with a hybrid closed loop insulin pump for only type 1 diabetic patient in UK. And here, if we see within a week or two, patient with type 1 is not getting good control, we offer them hybrid closed loop straight away. So we are using a lot, and we are seeing a tremendous good result with hybrid closed loop insulin pump system, especially in type 1, only in type 1 in UK at the moment.
Thank you, sir. But my participant is little bit angry that I missed one question about semaglutide and Ozempic. So in preconceptionally, can we use it, and during pregnancy, we should stop it or not? And in one line, Rubina ma'am, in your country, do you use semaglutide or Ozempic?
Yes, we do use it, but it is contraindicated in pregnancy. So the patient has to stop it well before planning the pregnancy, be on folic acid, and she should not be having the effect of Ozempic when she gets pregnant. And we do not recommend Ozempic in pregnancy.
Okay, thank you. Now we are near the end of the session. I just take one take-home message from everyone in 30 seconds. Maliha madam, one line, one take-home message for our young doctors who are dealing with this sort of patient.
So, diabetes mellitus is a risky factor for the pregnancy. So, every woman should screen for the diabetes. It can be the first chance of detecting the diabetes in the lifetime of the lady. So, every pregnancy should be screened for the diabetes.
Thank you, madam. Rubina ma'am.
Develop the necessary knowledge, skills, and attitudes to manage gestational diabetes. You will not be a popular doctor when you talk about advising the patients in reducing or modifying the kind of food they love to eat in pregnancy. It will make you an unpopular doctor. But you have to learn the necessary skills to get what you want from the patient for the benefit of the baby, and also not to become unpopular. So that is always an ongoing challenge, which I face actually every day. So that's my advice.
Thank you. Dr. Bita.
I think the most important message we should do here that we need to check everyone in Bangladesh or subcontinent for GDM or any pregnant woman. That's the most important thing. And if needed, we need to check it several times, which is mentioned. And also, I would like our junior doctors to remember the patient is always think about the individualized care. Do not think about the numbers or anything. So always think about, always speak to them or give them time, which will make you a better physician. That's it.
Thank you, sir. And any of our senior madam want to say anything? In one line, take home message. Samina madam first, and Saleha madam.
Okay.
In one line, any take home message, Samina ma'am?
Okay, one thing I want to say that this is a very wonderful session, and I want to give one information to all of you that from outpatient department of all our government hospital, insulin is available free of cost. So it's a great news for our women and also men that it is costly drug, but it is available. And another thing I want to know that whether deep sea we are not using most probably in Bangladesh, but Pakistan and India, they are using it, whether we should adopt it. And in the guideline, during my tenure of presidency, guideline we have contribution from the OGSB, and in that guideline we have mentioned most of these things that Tanzina has mentioned, and her presentation was very practical and informative. And one important issue that Rubina Sohail has said that in Pakistan, your OB/GYN people are doing the same, diabetes control is also done by them. But in our country, most of the time we are continuing with MDT.
Endocrinologist. Thank you, madam.
With that.
Thank you. Thank you for your nice ad. Professor Saleh.
Another point I want to add.
Okay,
that
madam.
we should assess the retina.
Yes.
We should assess the retina, and also we need to introduce cloud data.
Yes, madam.
These are the things we need to do in future.
Thank you, ma'am. Saleha madam, in one line, what's your take-home message?
Actually, Sharmin, I have a question actually.
Oh.
It is an excellent discussion, but one thing I say that pre-pregnancy counseling or checkup is an important part of management of pre-existing diabetes, as well as also diagnosis of gestational diabetes. But this is not a practice in our country. And we are actually doing the glucose tolerance test or diabetes screening test, not as a universal for only risk group of patients. So, but the pre-pregnancy counseling is not practiced and not actually available. So every patient should have a screening test, but our system is not ready. So
Yes.
glucose challenge test, can we take a glucose challenge test as a universal, like India, they take as the method DeepC method? This is one question. Another question, actually, that is also I think that is sometimes gynecologists and even sometimes endocrinologists says that though the target level is fasting is a 5.3 and after breakfast it is 6.7, but sometimes it is said that if it is fasting is less than 6 or 2 hours after is less than 7, that can be grossly or can be advised as a general.
Yes.
So what is actually what to do?
Tanzina Appa, do you give answer this question?
Thank you, madam. Actually, about the target, it is worldwide almost same that fasting should be less than 5.3 and 2 hour after meal should be less than 6.7 because these levels have been recommended because if you maintain these levels, then most of the complications we can avoid. And about glucose challenge test, yes, many of our doctors are still using glucose challenge test, I have seen, but the gold standard is oral glucose tolerance test, OGTT, and if it is feasible, we should always advise OGTT. And if there is chance that these women will not come back again, then we can offer her glucose challenge test at that moment.
Thank you very much. Thank you, Tanzina Appa, and all the panelists for joining. Thank you very much. Now is the time to end the session. In next month, we will again together with a new chapter, new session. Up to that, goodbye to everyone. Thanks especially to Rubina Sohel ma'am from Pakistan to join
Thank
with
you
us.
so much.
Thank you.
Thank
very
you.
much.
Thank you, Rubina,
Goodbye,
for your
everyone.
presence.
Okay,
Thank
goodbye.
you,
Lord.
everybody.
You are the family member of us. Yeah.
Yes, thank you so
Goodbye,
much for saying
goodbye.
this.
Goodbye.
Take care of yourselves. Thank you so much.
Yes,
And Tanjina, excellent presentation.
yes,
Thanks.
definitely.
Thank you.
Thank you. Thank you so much.
Excellent
Thank you.
discussion.
Thank you very much. Thank
Maliha madam, thank you, madam.
you.
Thank you. Thank you,
Goodbye.
Thank you, Ravina. Excellent presentation.
একটা দেখালো 2025-এ আমাদের হলো প্রি কনসেপশনাল কাউন্সিলিং ফার্স্ট, তারপর হলো যা ড্রাগ খেত আগে 6 মাস আগে থেকে ড্রাগ বন্ধ করা, তারপর হলো জিডিএম ঠিক করা, লাইফস্টাইল, ইকোস্পিরিন মাস্ট, অ্যান্ড দেন হলো ঘুম, এটা দেখলাম, স্লিপ প্যাটার্ন ঠিক করতে হবে।
And ophthalmoscopy.
তারপরে হ্যাঁ, না মানে এইটা হলো লাইফস্টাইল, যে তুমি যদি বাচ্চা নিতে চাও তাহলে ওই যেসব ড্রাগ খেতে 6 মাস আগেই বন্ধ করতে হবে। বলছে যে রিসেন্টলি এখন বলতেছে যে প্রি কনসেপশনাল কাউন্সিলিং আগে থেকে বন্ধ করো। অনেকে আছে না সেই ওজন কমানোর জন্য খাইতে আছে অ্যাডিপোলিন কি সব খায় না।
সবাইকে তো আনতে পারতেছেন না,
হ্যাঁ।
হসপিটাল ডেলিভারিতেও আসতেছে না।
যাই হোক, খুব ভালো হয়েছে সবার। টাইম আমরা
ওজেম্পিক নিতে দেখা যায় যে প্রেগন্যান্ট হয়ে যায়, এগুলোর অবস্থা তো খারাপ,
খুব খারাপ। ওই জন্যই বলছে, ওই জন্য রিসেন্টলি আমি আজকে দেখলাম 2025 ওরা এটা খুব বলছে যে তুমি 6 মাস আগে বন্ধ করো, ফলিক অ্যাসিড খাওয়া শুরু করো। তুমি ওজেম্পিক যে খাইছিলা তোমার শরীরে যা যা হয়েছে এতে প্রেগনেন্সিতে খুব হার্মফুল হবে, তুমি আগেই বন্ধ করো। দেন তুই ডিসাইড যে তুমি বাচ্চা নিবা, তারপরে তুমি আসো বাচ্চা নিতে। তারপরে তুমি ওই তখন থেকেই ওই গ্লুকোজ টেস্ট করানো। তারপরে বলছে যে তুমি যদি ও মেটফর্মিন খাইতো তাহলে ফার্স্ট ট্রাইমাস্টার বন্ধের পরে এটা ইনসুলিন, তারপরে হলো ইকোস্পিরিন বড় সপ্তাহ থেকে।
হিমোগ্লোবিন A1C করে নেওয়া উচিত, যাদের ডায়াবেটিস আছে শুড বি বিলো 6.5 or 6 বেটার।
সেটাই, যাই হোক, যেটা বলছে মাল্টিডিসিপ্লিনারি আমরা এখনো মানি, মাল্টিডিসিপ্লিন করতে হবে।
এখন আজকে আমাদের কাছে তানজিনা আছেই,
না মাল্টিডিসিপ্লিনারি তো আমরা করছি, কিন্তু ওটাও একদম খারাপ না।
শেখাটা তো ভালো, হ্যাঁ শিখতে পারলে তো ভালো,
হ্যাঁ সেটাও আমাদের শেখা উচিত।
শিখতে পারলে তো ভালো।
তারপর অনেক গ্রামে গঞ্জে পাওয়া যায় না। হ্যাঁ,
ভালো থেকো, অনেক দেখো, ভালো থেকো মালিহা।
ভালো থেকো, ঠিক আছে, তো দেখে যাবো।
Hmm.